This is EM Cases EM Quick Hits podcast. Quick, let's get on with it. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. It's my pleasure to welcome back Dr. Megan Landis to EM Quick Hits for part 2 of our 2-part Quick Hits series on what ED docs need to know about HIV. All right, if you haven't listened to part 1, where we outline why we need to have HIV on our radar, how to recognize it, and how to test for it, please go ahead and listen to that quick hit. In this quick hit, we're going to talk about HIV post-exposure prophylaxis, PEP, and pre-exposure prophylaxis, PrEP. I personally find this one pretty challenging because patients are often understandably exceedingly anxious. There seems to be a lot of uncertainty about the risk of HIV transmission, and I find the patient interaction ultimately is rarely satisfying. So we need to talk about source risk for transmissible HIV, risk of HIV transmission by type of exposure from an HIV-positive source, and risk assessment for PEP initiation. So let's start with what is PEP and what are the benefits of giving PEP. So again, we're talking about post-exposure prophylaxis. What exactly is it and why should we give it?
So PEP itself, or post-exposure prophylaxis, is an incredibly effective method for reducing the risk of transmission in persons who've been exposed to HIV. The important thing is that it needs to be given at less than 72 hours from actual exposure. It's prescribed as a 28-day course of ART, or antiretroviral therapy, and it reduces the risk of that single exposure by 80%. So it reduces your risk of a percutaneous exposure to HIV-positive blood to 0.3% and a mucocutaneous, so in the mouth, in the eyes, in the vagina, to 0.09%.
Okay, so that's quite a risk reduction, 80% risk reduction. So this stuff really works well.
I think the thing to clarify is that every single exposure risk is a relatively low risk when we think of HIV. So we are reducing the relative risk to exposure by 80%.
Okay. So we're reducing a very small risk to
an incredibly tiny risk.
Got it. Okay.
Yeah.
Let's talk about who should take PEP. So in order to figure out the risk of transmission, we first need to know the source risk for transmissible HIV. So the characteristics of the person from which the bodily fluid came. So what is the risk of HIV transmission when it comes from that source?
Right. So that's absolutely the first step. And there really are 3 key steps to figuring out the transmission risk, and they're really nicely outlined in the 2017 Canadian Medical Association Journal. I think it's important to note that this paper is quite specific to the risk in the general population to exposure and is not specific to the policies for occupational exposures that might exist in your hospital for needle sticks. And every practice setting has their own policies at your own hospital, and I would encourage everyone to know what those are, because we do a ton of advising after hours for hospital employees when occupational health is closed. However, back to the question at hand, for sure, figuring out the source risk is the first step. And the source risk for transmissible HIV can be categorized into substantial, low, but non-zero, or negligible. To start with substantial, the source risk is substantial if the source is HIV positive and has a high viral load. Also, if the source comes from a population with a high HIV prevalence. So that is our classic risk factors, like persons who inject drugs. The second category is low but non-zero. So in that category is a source where the person is HIV positive and they have a low viral load, so they are considered suppressed. However, at the time of the exposure, they have a concomitant sexually transmitted infection. So sexually transmitted infections modulate your risk of transmitting HIV by breaking down mucosal barriers, increasing inflammatory states, etc. I think it's important for us to know what risks are negligible. So, of course, in a patient in a source which has confirmed HIV negative status, but also a source who is a person who is HIV positive with a confirmed viral load of less than 40 or otherwise undetectable, and no known STI at the present time of exposure. And the final negligible source risk is from a source whose HIV status is unknown, but comes from the general population, which does not have any risk factors for HIV.
So those categories, there's some surprises in there for sure. I mean, I would think that anyone who is confirmed HIV positive, no matter what their viral load, would be a substantial risk, but they're not. They're actually in the low but non-zero risk. If they have an STI at the time of exposure and they're in the negligible to none risk, even if they're HIV positive, if they have a confirmed viral load less than 40, so undetectable viral load, and there's no known STI, that's actually in the negligible category, which is really surprising. We're going to have the table in the show notes because I think it's easier for people to follow the table. And I actually just used this quite recently in the emergency department. I found it very helpful to use this exact table.
So can I just say to that surprising finding that an HIV positive source with a confirmed viral load of less than 40 and no known STI at the present time of exposure is based on really excellent evidence. We have very large cohort studies that have followed serodiscordant patients over time, recording sexual encounters in which the patients have not been using barrier protection. And there were 0 transmissions that were genetically linked in those incredibly large cohorts. So I'm referring to the partners studies. And this has led to the really powerful slogan that undetectable means untransmissible, which you'll see within literature.
Okay, so that's step 1 in figuring out the source risk of HIV transmission. Step 2 is figuring out the risk depending on the type of transmission. So is it needle stick versus mucocutaneous splash of body fluid versus sexual act or something like that? What is the risk of getting HIV from a needle stick or a splash of blood in the face during a medical procedure or from a sexual encounter?
So we know that the highest risk of transmission per act is either through anal receptive intercourse, which the estimated risk per act in that situation is 1.38%, or needle sharing. So if you are exposed to a needle, which from an HIV positive source with a high viral load, it's a 0.63% per act.
Well, so that actually, 0.6% per act, even when it's a known HIV and you're sharing needles. So that actually doesn't sound very high. It's another surprising statistic there.
And that's why it's important to think about the relative risk reduction of PEP. So it's an 80% relative risk reduction. So we're reducing a 1.38% risk per act by 80%.
Got it. So the high risk transmission is anal receptive sexual act, which is about 1.4%, and sharing needles in a known HIV person is about 0.6%.
Right. And then in the moderate category, we have anal insertive, vaginal receptive, and vaginal insertive. So those risks range from 0.04% to 0.1%. And the lowest risk categories, which the actually precise estimates aren't even really available, are either giving or receiving oral sex, oral anal contact, sharing sex toys, and blood on compromised skin, which has come up multiple times in the emergency department for me on a regular basis. So I find this table exceedingly helpful.
Okay, so that gives me a pretty good idea about needle stick injuries and sexual encounters in terms of the risk of transmission of HIV. What about mucocutaneous, like a mucocutaneous splash, for example?
Yeah, you'll note that it's not in the table that we are referencing. However, we don't have great data for it. There's a number of case reports. You may find in your own occupational health policy for an occupational exposure specific policies around that, but I would encourage you to look at your hospital policies.
Fair enough. All right, so now we know the risk of the source, and we know the risk of the type of the encounter, as well as the degree of risk reduction of PEP, which is 80%. So now we're ready to decide whether or not to start PEP. So that is if the person in front of us in the emergency department, depending on their level of risk, should be counseled to start PEP. So which patients, based on your risk assessment, should be advised to start the PEP, and which patients should be advised against it?
So really the bottom line is that there's only really two slam dunks. So simply put, it's a slam dunk to give PEP if the source is in the substantial category and the type of exposure is high or moderate risk. Please give PEP. And it's a slam dunk to not give PEP if the exposure type is low and the source risk is negligible or none.
Okay, so we've got kind of the two extremes. You have to be substantial or high risk source and high or moderate risk type of exposure. That's when you would give PEP, and you do not give PEP if it's a low risk source and a low risk type of transmission. Then there's everything in the middle where it becomes a little bit more challenging. But if you have these tables in front of you with the patient, then they can make it an informed decision based on the evidence, as you said. All right, the last question we need to answer before deciding on whether or not a patient requires PEP is what the downsides of taking PEP are. What are the side effects of PEP and the cost considerations as well?
So really, there's very few side effects with new versions of antiretroviral therapy, and it really depends on the drug treatment, but we've seen tremendous improvements in tolerance of these drugs over time. Often the side effects can be GI related mostly. One of the things that is also noted is that antiretroviral therapy is not cheap. So the cost is significant, even though it has also been decreasing over time. Certain drugs are much more expensive than others. And I think if there's a concern, I know in our emergency department, we have a PEP kit, which we give for 3 days in order to try and figure that out. So we're not wasting time about figuring out how to get the medication. And I would also involve social work and your infectious disease colleagues or your local STI or HIV clinics, depending on where these patients will go for follow-up, as they often have ways of accessing medication or ideas or programs for supporting patients who can't afford these medications.
I understand that some patients are taking ART as pre-exposure prophylaxis. So that's the PrEP, not PEP. And so, in other words, they're taking it on an ongoing basis, not just after a single high-risk exposure, because they're expecting to have repeated high-risk exposures. What do we need to know about pre-exposure prophylaxis or PrEP?
Pre-exposure prophylaxis is for high-risk individuals to take on a daily basis antiretroviral therapy in order to prevent infection. And Truvada was approved by Health Canada in 2016 for this purpose. And we know that it has a relative risk reduction of 44%. The number needed to treat is incredibly low. So it's 1 in less than 15. And when we think about using statins to prevent an MI, that number needed to treat is 1 in 250. So it just shows that this is a highly effective medication for this purpose. And the people who should consider taking it are adults who have ongoing exposure, so sexually active adults who have high and ongoing risk of infections. That would include people who have ongoing condomless sex with known HIV exposure. Some other things that you can think about in the emergency department that I think are particular to us, maybe triggering a conversation about PrEP, are people who've had a recent STI, because we know they've had sexual exposures, and also people who are presenting to the emergency department for recurrent PEP. So people who are coming over and over again for post-exposure prophylaxis may want to think about a strategy such as PrEP, which may be better for them in terms of risk reduction, but also probably lifestyle. One of the things I think which is interesting to think about is there are current ongoing studies and evidence emerging about doxy-PrEP. So that is adding doxycycline to a PrEP regimen, so a once daily ART pill, in order to prevent STIs, in particular bacterial STIs and syphilis. There was a recent paper published in the New England Journal of Medicine in 2023, which showed good effect in a PrEP study. And so you probably are likely going to be seeing patients coming in on doxy-PrEP or even asking for it. There is also evidence for potentially using doxy-PEP, which would be giving PEP plus a dose of doxycycline in order to prevent syphilis. But the evidence right now is very locally variable in terms of its efficaciousness, and it hasn't come into standard practice, but you may see people asking for it as well.
I just want to clarify one thing. My understanding was that the standard treatment for syphilis is penicillin. So why would doxycycline be given as PEP? Shouldn't they be giving penicillin as PrEP?
Absolutely. You're right. So 100% penicillin is still the standard of care for syphilis treatment for a diagnosed infection. However, the evidence from these studies are emerging that we can actually reduce the risk of syphilis by a single dose of doxycycline.
Well, doxycycline is like this miracle drug. It can, prevent Lyme disease, pretty much every STI, every bacterial STI, malaria, and syphilis as well.
It can cause a nasty sunburn, though. So we all shouldn't start taking it on a regular basis.
For sure. So we packed in a lot of pieces of information into this quick hit. And I think this is exactly the kind of topic where having a table, as we alluded to, in the emergency department or having resources in your ED would be very helpful because it's hard to remember all the exact risk factors and such. Can you suggest some bedside online resources for ED docs to help them assess HIV risk and decide on prescribing PEP or PrEP?
Absolutely. So in terms of Canadian guidelines, the CMAG paper that we were talking about from 2017 by Daryl Tan et al. Is the standard by which we should be making decisions. Just to be aware, that paper is undergoing another revision to update those guidelines, and it should be out sometime in 2024, so you can keep an eye out for that. In terms of PrEP, either as a health provider or a patient, in Ontario, there is a website, www.ontarioprep.ca, where you can get more information about PrEP itself. And I would encourage you to get familiar with where PrEP clinics are in your community. So it might be your hospital infectious disease clinic, as it is for us in downtown Toronto. However, there are physical PrEP clinics that are set up in order to manage this. So in Toronto, there's the PrEP clinic as well as Headquarters Toronto. And also patients can access PrEP online, which is really reducing the access barrier. So there are two websites, www.gofreddy.com as well as at theprepclinic.ca, where patients can fill out a form, get an assessment, and start on PrEP online.
Is GoFreddy, are they referring to Freddie Mercury?
I have no idea.
Yeah, seems like a strange URL for
I have HIV no idea.
PrEP, but my guess is that they're referring to Freddie Mercury.
Maybe.
Could be. All right. Well, I think I'm going to feel a lot more comfortable assessing patients for the risk of HIV transmission and advising them for or against PEP and PrEP going forward. Thank you so much, Dr. Landis, for your insights in part 1 and part 2 of this Quick Hit series. Insights into a virus that we all need to be on the lookout for in the ED. It's quite clear to me that we have a very important role to play, not only in identifying HIV in the ED to save our patient's life, but to save other people's lives by early diagnosis and initiation of treatment. And now for the best of University of Toronto emergency medicine.
This trial is huge. You're going to hear about it everywhere, and it might just change your practice. So let's talk about using BiPAP for pre-oxygenation prior to intubation and the PREOXI trial that was just published in the New England Journal of Medicine. Now, it might sound a little bit crazy to some people. I know I've gotten a lot of pushback in the past when trying to do this, but there are a lot of reasons that using non-invasive positive pressure ventilation makes a lot of sense specifically for pre-oxygenation. And I'm not talking about using BiPAP in COPD or asthma in an attempt to avoid intubation. or even using a wait and see approach. I'm talking about a patient who you are planning to intubate imminently, but still using non-invasive specifically to make that intubation safer. The issue is that oxygen hemoglobin dissociation curve. We all know about it. We know that it gets steep right about 90%. And that if our patients have a SAT in the low 90s when we start intubating, even though that number looks very normal to us in the emergency department, those patients can easily and very quickly desat and even arrest. Now, assuming that you have an open airway and the patient is receiving oxygen at flush rate by non-rebreather and they're making some ventilatory effort, there's really only one reason that their SAT could possibly be low. The patient is drowning. Their lungs are full of crud, whether fluid from CHF or pus from pneumonia. You have VQ mismatch and shunt physiology. And the only way to fix shunt is with PEEP. And there are a couple ways that we can provide PEEP in that pre-oxygenation phase. A PEEP valve with a bag valve mask holding a good seal and nasal prongs underneath set to 10 liters a minute, that will work, but it's not always easy. The easiest and probably most effective thing to do is just to use the device specifically designed to deliver BiPAP or CPAP. And I've been teaching that for a long time, but admittedly without good evidence. But that changed just a couple days ago. The PREOXI trial just dropped in the New England Journal of Medicine. This is a multi-center RCT that randomized 1,300 critically ill adult patients, either from an ED or an ICU, to either have face mask oxygen higher than 15 liters a minute or BiPAP for their 3-minute pre-oxygenation. Now, I'll mention they used BiPAP. Strictly speaking, all you need to deal with shunt and improve oxygenation is CPAP. But I think the logic here was that some people will need some ventilatory support, and rather than complicating things, they just want to make the protocol as simple as possible. One size fits all. This is a pragmatic trial, so airway management was not strictly controlled. But if you read through the manuscript, you'll see that they make a number of recommendations and they all seem very reasonable to me, all keeping with my standard practice. Face mask was by flush rate oxygen. You were allowed to use nasal cannula for apneic oxygenation. You were allowed to bag during the apneic period, all things that could have affected generalizability. The patients look exactly like the kind of patients I do intubate in the emergency department, mean age of 61, half were presenting with hypoxic respiratory failure. Like a lot of studies, most of the intubations, almost all, were done by residents and fellows, and that can sometimes be concerning, but these learners had a median of 50 prior intubations, so it's not like they were pure novices. The key outcomes. Well, their primary outcome was peri-intubation hypoxemia, defined as an oxygen saturation of less than 85% in the interval between induction of anesthesia and 2 minutes after intubation. It occurred in 9% of the BiPAP group and 19% of the face mask group. Statistically significant, an absolute difference of 9% or a number needed to treat of almost 10. I really like that they used 85% here rather than that normal 90% because a brief 30-second dip to 88% really is not that clinically relevant. They also tell us about patients who drop below 70%, which is definitely significant. It was 2% with BiPAP and 6% with a face mask. Peri-intubation arrest, it's only a secondary exploratory outcome, but it's clearly the most important clinical outcome. It occurred in 1 patient, or 0.2% of the BiPAP group, as compared to 7 patients, or 11% with the face mask group. And there was no difference in aspiration or any of the other safety outcomes. So across the board, this trial shows a pretty big benefit from pre-oxygenation with BiPAP. This is a good trial. It's an important trial, but of course it's not a perfect trial. No trial is. So let's talk about a few limitations before we decide on our clinical application. First, this is an unblinded trial, and unblinded trials always add a ton of bias. Now, for the most part, they're looking at oxygen saturation. That sounds like a pretty objective number here, but even oxygen saturation is not perfectly objective, right? Especially in our critically ill patients who have low flow states, you often get poor readings. You don't know if you should trust the numbers, and I gotta say, if you're seeing a number on the screen that fits your study hypothesis, you might just be more likely to write that down, and that's where the bias could come in. The next limitation is the primary outcome. And look, I think this is a good primary outcome. It's an outcome that I do sort of care about, but it is a surrogate monitor-based outcome. It's a surrogate with strong associations with clinical outcomes, but it's not a patient-oriented outcome itself. It's an outcome I think is important enough to potentially guide my practice, but I think a mental adjustment needs to be made here. Most patients with brief hypoxemia are fine, right? SATs of 82% for 30 seconds probably has no long-term outcomes. So although we talked about an absolute risk reduction of 9% or a number needed to treat of almost 10, that's for the SAT probe. That's not for clinical outcomes. Only a fraction of those patients will have a real clinical outcome. So the real benefit will be smaller, or the number needed to treat will be higher. And I think that's going to be an important consideration when you start thinking about a cost-benefit analysis here. There are a couple issues with the population. Number one, a lot of trials do this, but they let the clinicians exclude anybody where they thought non-invasive was either absolutely needed or contraindicated. And that makes sense to some extent, but it means that you might be excluding exactly the patients where this would work, which would bias the trial towards the null hypothesis, but you also might be excluding the exact patients who are more likely to have an adverse event. So this trial would be biased against showing us possible harm, and that's problematic. The other problem I have is I think this trial population might be too broad, right? I think if somebody's satting at 100% on face masks, they don't need this approach. And that's sort of the majority of my patients. So I think if they had just limited this to only patients with signs of shunt, say patients who are 95% or lower despite 100% oxygen, I think you would see even bigger benefit here. In general, because of those limitations, replication is the core of good science. A lack of blinding adds a lot of bias. You'll almost never find me suggesting practice change after a single unblinded trial. However, another core of good science is Bayesian thinking, consideration of the pretest probability. We know non-invasive works great. We know that it is safe. Even before this trial started, it had a very high chance of success. So what is our actual clinical take-home here? Well, for the average doctor, I think this is practice changing. I think a lot like delayed sequence intubation, the question is not whether this should be used. Of course this should be used. The question is, how often should we be using it and which patients really need it? And although it will change practice for a lot of people, it probably actually won't change my practice because I was already doing this. If I can get a patient to 100% with a non-rebreather at flush rate, I think that's good enough. I'm not going to start using non-invasive in those patients. I don't think oxygenation is going to be an issue. But if I can't get the SATs above 95% with a non-rebreather, assuming the patient is moving air and has an open airway, then I know there is shunt and I know that patient needs PEEP. And there are a number of different ways that PEEP can be delivered in the pre-oxygenation phase. And the exact approach you take will probably depend on the resources at your hospital. But using the vent, which you're going to need anyway in the post-intubation period to provide CPAP or BiPAP, well, that just makes a lot of sense to me.
Thanks so much, Dr. Morgenstern. Given that there's quite a bit of controversy around what we should take away from the PREOXI trial, I asked Canadian airway expert George Kovacs for his thoughts on the trial and to dig a bit deeper into the nuances of pre-oxygenation before endotracheal intubation. Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. Take it away, Dr. Kovacs.
George Kovacs here. Great study. Love the review by Justin. Here's my take. Is it going to change practice? No. But as Justin said, it's because this is what we've been doing. A couple important points. One is we can't look at all of our patients the same, and the way we look at it is pretty simple. There's two groups of patients, is abnormal lungs and normal lungs. And normal lungs It's as simple as nitrogen washout. Fill the reservoir with 100% oxygen. You take their reservoir for their FRC that was 400 mils, and you turn it into 2,500 mils, and they will have lots of time for what we're doing this for is to have safe apnea during laryngoscopy intubation as part of an RSI. So that's what we do. We can just put them on a non-rebreather, these patients. If we think that they require more, we can go up to flush rate. In other words, going beyond where the ball goes at 15 liters per minute, cranking it up, and they will go as high as, say, 50 to 60 liters per minute in North America with these regulators. And we're doing this essentially to ensure that we're meeting their minute ventilation needs. So sick patients have higher minute ventilation, right? And might exceed the 15 liters that we're used to delivering for you and I would be fine. And if you don't exceed their minute ventilations with the oxygen that you're delivering, then where they're going to get that extra flow from is by entraining room air, and that will dilute your FiO2. Right, so there's a group with normal lungs, and you don't require pressure. You just have to ensure that you're delivering an FiO2 of 100%, and you do that by exceeding their inspiratory flow rates, and you're going to be fine. And for patients that have abnormal lungs, which is a different group, then you have to approach them differently. And you need to provide pressure. You need to recruit alveoli. So it doesn't matter what's going on in their lungs, whether it's pus or whether it's fluid or whatever. These patients have what's been referred to as baby lungs, because they've got alveoli that are filled with stuff. So the volume of lung is less. And what you need to be able to do is recruit alveoli. And the way that we normally recruit alveoli is by applying PEEP. And all PEEP is you're blowing against a pressure, and that pressure then backfills and fills up the alveoli and recruits others. It's more complicated than that. We've all seen, I think, dramatic videos of this. And on our YouTube site, we've got some great open lung examples of the magic of PEEP. The way we deliver that, most of the time, we can deliver that with our BVM, and we advocate using what we call super BVM. So you've got your BVM, you've got the expiratory port, which has got a PEEP valve on it. You've got a pressure manometer that's attached to another port, the same port that you would administer. It's actually the MDI port. And then you have your viral filter, and on the viral filter is a port that you attach your waveform capnography. And this is critical. And remember that all of you right now have a saturation of 99%, right? But it tells you nothing about safe apnea time. And that's what we're trying to do here. Our purpose is to ensure that during laryngoscopy and intubation, you're going to be able to safely capture the trachea with a tube. Laryngoscopy and intubation is going to be able to be done without significant physiologic and, more important, other consequence of morbidity and mortality. That's what the goal is here, right? So what we need to do is, again, fill that lung with oxygen, denitrogenate it. And in patients with baby lungs, we have to recruit that. And the way we recruit is by applying PEEP, which can be done with our BVM, with them spontaneously breathing. When what we'll do is you'll dial up to a PEEP of about 10, have nasal prongs underneath that at a flow rate of 10, and have your BVM from the wall at 15 liters per minute. You're keeping an eye on that reservoir bag, make sure it's not collapsing, right? Because they are spontaneously opening up the valves in the BVM to draw from that reservoir. And the way that you know that you're actually delivering what you think you're delivering is by looking up a waveform and saying that you've got a nice top hat appearance, not this variable height and shape of your waveform trace, but you've got a nice clear and as close to a top hat as possible. And it doesn't always look perfect, but that ensures that you're delivering what you think you're delivering, because it tells you everything about seal. So it's giving you breath-to-breath information, and that is key. I've been in situations where patients they're preparing to intubate them, they're pre-oxygenating them with super BVM, but they don't have waveform capnography, and they can't get their sats up, so they just say, okay, we're going to just abandon it and go for it. And when it's, listen, just hook up the waveform, they hook up waveform, realize that they didn't have a good seal, and so they adjust it. And with that, they get a good seal, and all of a sudden their saturation to improve to a safe level for them to do an RSI. So the issue is with the study is how they grouped what was non-invasive ventilation as a pre-ox tool versus all the rest. And I think we need to look at it in a bit more detail. Look at it, patients with normal lungs versus abnormal lungs. Patients with abnormal lungs, we have to use more aggressive and advanced tools, and you can use super BVM. But what the problem is with super BVM is that we can turn this poor person's CPAP, which is just a device and letting them breathe spontaneously, to BiPAP, where what we're doing is helping the inspiratory phase. So during inspiration, we're giving a little pressure support, and this is BiPAP, and we can use poor person's BiPAP by using our BVM and assisting them. The thing is it's pragmatically very difficult to do unless you're really skilled and are very dedicated to have one person, just looking at the chest as they try to do it and deliver it with every second breath, because their respiratory rate is 30, and you trying to give a rate of inspiratory time breaths with your BVM, that's just not going to happen. It's not going to happen effectively, and you're going to fill their stomach with air and add to the pizza and beer. And when you put them supine or to that head back and head elevated position, they're going to still regurgitate and cause a mess. This is when it's really important to use a non-invasive mechanical device. Non-invasive mechanical device where, it's providing PEEP, right? And it's triggered, the inspiration pressure support is delivered by inspiratory effort. So the inspiratory effort causes that breath to be delivered by the machine, right? So you don't have to worry about timing, and you're going to be able to do that safely. The big caveat is if you're doing an RSI, when you render them apneic, there is no trigger, right? So you know that when you're bagging the patient, because you're bagging them, you can continue to take over their ventilation during that induction period where you can assist them. So you need to make sure that your device is delivering, ideally, your mechanical device is set up, and your RT, whoever's helping you, that it's set up to deliver the same respiratory rate that was going on in the pre-intubation phase. So if their respiratory rate was 30, then you want to continue it through 30. And that'll avoid that relative hypoventilation that can cause an elevated CO2 and cause, potassium badness with worsening acidosis. So another reason to use non-invasive ventilation during that phase. Now, again, you're going to have to take that off, and underneath that, you can have your nasal prongs, and you can continue to apply that during laryngoscopy and intubation. So for the patients, they're still very sick, even with BiPAP. Their saturations are 91, 92%. And I know that with that, their sats are going to fall about 1% every 2 seconds, and there will be a nurse in the room that will be counting those numbers off as they fall. And what I will do in these patients, I will spend the extra money, and I will not only have non-invasive ventilation throughout this, but I will have high flow oxygen on their forehead, not to do transdermal oxygenation, but to drop down during laryngoscopy and intubation when I take that mask off. And again, you need to be in there very quickly, because as I said, you lose all the recruitment effect as soon as that pressurized mask comes off. That's it in a nutshell. One final thing is that people talk about, is it significant if their sats drop to X, Y, or Z? I really think that we've missed the boat here, and I'm halfway through writing an editorial on this, on first pass success, who cares? because it really is about the physiology, disturbances that cause consequence and not the number of passes, and we need to be able to do this safe. It's all about having safe apnea. But everybody remembers, okay, George couldn't intubate that patient. You hear about that last night? Or the person had a cardiac arrest, or the patient died post-intubation. Nobody says, oh, listen, remember that case from last night where their sats dropped for 30 seconds or their blood pressure dropped to, 70 for 15 seconds. Nobody remembers that. But if you follow these patients out in the Intube trial study, published in JAMA, 29 countries, and if you'll look at the events, peri-intubation events, showing all kinds of things. The most important one is that we're using big dose too many people are using big dose propofol. But the other important thing is to recognize that it's the hypotension and severe hypoxemic events. If you follow them out over time, there is significant morbidity and mortality. It's just not declared in the ED where you see it at that time. So it is important to try to avoid this. Doing it with non-invasive ventilation is the way to go. We've been advocating that forever. There is some recent evidence saying that high-flow nasal oxygen, OptiFlow, Vapotherm, whatever you use, can be very effective as a pre-oxygenation tool. First of all, it's tolerated by our patients, and it can be used other than the most critically ill, people with PF ratios of under 100 or 150. One last thing about tolerance versus non-tolerance, don't abandon it. If they're not tolerating your pre-oxygenation method, then use what we refer to and have been referring to as facilitated cooperation using ketamine, otherwise known as DSI. Those are my thoughts. I think it's great to have this evidence out there. Non-invasive ventilation is important. Using a triggered mechanical device to provide that inspiratory pressure support as well as PEEP is the way to go, and provide it throughout the pre-oxygenation phase, through the induction phase. Think of patients as sick lungs, bad lungs, or okay lungs in terms of your decision-making.
Incredible insights, Dr. Kovacs. You cleared up so many questions I had about which situations to use which tools for pre-oxygenation and how to use them as well. So thank you so much. By the way, both Dr. Morgenstern and Dr. Kovacs will be speaking at the online International EM Cases Summit, November 21st to 23rd. Registration is currently open at emcasessummit.com. That's emcasessummit, all one word, .com. Now, switching gears, there are really only a handful of true oncologic emergencies, and one of those that we usually only diagnose when the CBC comes back is, you guessed it, blast crisis. Here's Brit Long on the recognition and management of blast crisis, and I think the key here is that while, yes, in the ED we can give antibiotics and we can transfuse platelets if they're in the boots, the cornerstone of management is treating the leukostasis with induction chemotherapy and or leukapheresis, which we need a consultant for ASAP. So the bottom line is, as soon as you see more than 20% blasts in that CBC, you need to call your consultant immediately.
When you hear oncologic emergency, the first thing that might come to mind is febrile neutropenia. This was covered in Quick Hits episode 35, but there are several other dangerous oncologic emergencies. For this Quick Hits episode, we're going to look at blast crisis. This comes down to too many blasts or immature white blood cells in the serum, which causes severe end organ injury and some other major problems. Let's start with a definition. Blast crisis is defined as greater than 20% blasts in the peripheral blood or bone marrow, or an accumulation of blast cells outside of the bone marrow. In most cases, blast crisis occurs in patients with chronic myelogenous leukemia, or CML. CML accounts for about 20% of adult leukemias, usually around the age of 50, and it's marked by several phases. The majority, around 90%, remain in this chronic phase. Up to 10% can progress to an accelerated phase with 10 to 20% blasts. This can then progress to blast crisis in about 1 to 2% of patients. However, anywhere between 1 to 7% of patients with undiagnosed CML can present with blast crisis. Also keep in mind that up to 30% of patients with ALL or AML can present with leukocytosis and high blast numbers, just like a blast crisis in CML. Unfortunately, blast crisis is deadly and it has a very poor prognosis. The median survival is 7 to 11 months after diagnosis, and that's if they survive the initial diagnosis of blast crisis with its many complications. So why is this a problem? Well, there are 4 different issues. First, the proliferation of blasts in the bone marrow can crowd out other cell types. This leads to anemia and thrombocytopenia. The second problem is that the blasts don't function as mature white blood cells. This means these patients are immunocompromised and at high risk for severe infection. Third, patients with white blood cell counts over 100,000 are at high risk for leukostasis. This is a clinical syndrome of too many white blood cells and end organ injury. Leukostasis is still possible with white blood cell counts less than 100,000, but it's less likely. We don't quite understand the exact mechanism behind leukostasis, but it's probably due to high blast counts and hyperviscosity causing obstruction in the small blood vessels, which leads to end organ ischemia. The fourth and final issue is another oncologic emergency, tumor lysis syndrome. This results from rapid cell death, which releases intracellular contents like potassium, phosphate, and uric acid. Tumor lysis syndrome can present with vague symptoms, fever, nausea, fatigue, all nonspecific. Patients may also be referred to the ED by their oncologist or primary physician due to some abnormal lab results. With that, let's look at how blast crisis can present. Fever, night sweats, weight loss, and bone pain are common presenting symptoms in patients with blast crisis. Fever occurs in up to 80% of patients and can be due to a primary infection or the malignancy itself. Patients may be symptomatic from their anemia with chest pain, shortness of breath, and thrombocytopenia may present with bruising, easy bleeding, or petechiae. Beyond these vague symptoms, the 2 most common organ systems affected in blast crisis are the pulmonary and the neurologic systems. Pulmonary involvement is actually the worst prognostic indicator in leukostasis. Pulmonary complications of leukostasis can range anywhere between mild dyspnea with exertion to severe ARDS. You may find rales and crackles on exam, and the patient may be in respiratory distress. Neurologic complications of leukostasis vary. These might include headache, dizziness, vision changes, ataxia, focal neurologic deficits, altered mental status, and even intracranial hemorrhage. The workup hinges on first the CBC with differential and peripheral smear. Beyond that, I mentioned those 4 different issues, and patients often have several of these together. The key is not to anchor on working up the patient for just one complication. All of these issues can be deadly. Other important lab tests include a renal and liver function, electrolytes, uric acid level, phosphorus, coagulation panel, type and screen, fibrin split products, and then finally a fibrinogen level. You're basically looking for end organ injury, issues with coagulation, and tumor lysis syndrome. Because these patients are at high risk for infection and they probably will present with a fever, blood cultures, urinalysis, and urine culture are also important. Imaging should start with a chest x-ray to look for infection or pulmonary complications of leukostasis. Interstitial or alveolar infiltrates are signs of pulmonary leukostasis, but these findings are nonspecific and they're not needed for a clinical diagnosis of pulmonary leukostasis. If the patient has neurologic symptoms, then obtain a non-contrast head CT. The final component is treatment. Your first goal is emergent oncology consultation. While we're waiting to speak with the oncologist, we need to think about all of those problems with blast crisis. First is the anemia and thrombocytopenia. Avoid transfusing these patients with RBCs if possible. This can worsen the leukostasis. Transfuse the patient only if they're severely symptomatic, they're unstable, or they have severe bleeding. For platelets, your transfusion threshold is 20,000. Levels below this significantly increase the risk of intracranial hemorrhage. Second is infection. Blast crisis can present just like sepsis. Because they have poorly functioning white blood cells, think of these patients as neutropenic. Give broad-spectrum antibiotics if you find a focal infection, if they have a fever, or just if you're suspicious of infection. Third is the acute leukostasis. These patients need leukapheresis and or induction chemotherapy, which is why we need to get oncology on board early. Try to avoid diuresis if you can. This isn't going to help with their symptoms and can worsen the leukostasis. Finally is tumor lysis syndrome. This is diagnosed with the Chiaro-Bishop criteria, which includes cardiac dysrhythmias, seizures, and several lab findings. Treatment for this is going to be IV fluids, avoid giving calcium unless the patient has an arrhythmia due to hyperkalemia, and finally rasburicase. This is an enzyme that breaks uric acid into compounds that can be excreted. Patients may also need hemodialysis. So, what do you need to know for your next shift? The key take-home point is that blast crisis is defined as greater than 20% of blasts in the peripheral blood. There are 4 issues with blast crisis: anemia and thrombocytopenia, increased risk of infection, leukostasis, and finally tumor lysis syndrome. In the ED, speak with your oncologist, resuscitate the patient, and get them moving towards leukapheresis or induction chemotherapy.
And now a word from one of our sponsors, Easy Resus, the resuscitation assistant. Did you know that Easy Resus is brought to you by a non-profit organization dedicated to improving care in resuscitation? This means that every dollar from your subscription goes to improving Easy Resus. But not only that, thanks to your contributions, Easy Resus can be made affordable for healthcare workers in developing countries so that they can also deliver the best care possible to their patients. If you want to help them in their mission, download Easy Resus and use promo code EMCases to get your first 2 months free, or visit easyresus.com/EMCases for more details. All right, next up, we have the dynamic duo from Ireland, Dr. Leah Flanagan and Liam Loughrey from the Case Report podcast, with a fantastic tox case.
So, welcome guys. Grab a cup of coffee and join myself and Liam for something a little bit unusual this week. We've got a sinister case for you of a recreational drug that's unfortunately on the rise in recent years. Sound good to you, Liam?
Absolutely. Let's get to it.
So it's 8 a.m, you finish your morning handover and you take your coffee and head to the miners area. You pick up the next card of a gentleman who's waiting to be seen. He's 21. The triage note seems slightly vague, with normal vitals and pins and needles to his feet. You bring him into a surprisingly free assessment space and start to get a little bit of a background from him. But he stumbles walking into the room slightly, and you note that he almost looks like he's walking on the moon. It's subtle, but you spot it, and it certainly isn't normal. For an overnight in the waiting room, he looks startlingly awake and appears quite worried, and there's a slight smell of marijuana following him.
Okay, I don't think there's going to be any need for the coffee to wake me up here. We've got a young, ataxic patient with vague sensory symptoms who's waited all night. There's a lot of alarm bells going off in my head. So what does he tell me?
Right. So this is a 21-year-old man who hasn't been to hospital before, and he isn't on your records. He says that over the last number of weeks, he's been experiencing some lower limb tingling. He first noticed it when he was out walking one night and felt a bit unsteady. But given that it's winter, he initially put it down to his feet, just feeling numb in the cold. But it persisted, and he's beginning to feel slightly off balance.
Okay, so I'm going to want to get quite a thorough history here, as the differential for paresthesia is quite wide, whether it's worsened or spread to other areas. Has he had any other neurological symptoms like visual changes? Thinking of things like Guillain-Barré and infection, I'd want to know about any recent illnesses or fevers, whether symptoms are ascending, any features of cauda equina or lower back pain. I think it's going to be really key here to get a good social history, so looking at alcohol intake, drug use, a sexual history, as well as his occupation. And I'd also check for anything significant in his family history, thinking here about things like diabetes, neurological conditions, or autoimmune conditions.
Great. So the patient denies any back pain, recent illness, any other symptoms. He has no symptoms of cauda equina, he's passing urine normally, no subtle anesthesia, and no fecal symptoms. And he's in a monogamous relationship with a single female sexual partner since his last STI screen. The paresthesia is isolated to his feet, has been intermittent until lately, and now it's persistent. He has no other past medical or family history. He is currently job seeking and smokes 5 to 10 cigarettes per day. He cautiously admits to occasionally using balloons or whippets or nitrous oxide, but his demeanour makes you think that he might be underestimating that.
Okay, I'm starting to get a bit worried about the paresthesia in the context of nitrous oxide use, particularly in the absence of any other red flags that point to an alternate diagnosis. Are there any significant exam findings?
Cardiovascular, respiratory, and abdominal examination are all normal, so you do a thorough neurological exam. Upper limb tone, power, coordination, sensation, normal. Reflexes in the upper limb are normal, except for a positive Hoffman sign. Tone and power is normal in the lower limbs, except for ankle dorsiflexion, which is about 4 out of 5 bilaterally. You find loss of vibration sense to the level of the medial malleolus. Light and pinprick touch is normal, and there is symmetrical loss of proprioception at the feet. So ankle jerks are absent, and the patient is Romberg's positive, so abnormal, and you wonder if something's going on in his posterior columns.
So to recap, we've got a 21-year-old male with a history of at least intermittent nitrous oxide use, with significant abnormalities in power, proprioception, and reflexes. Tying this all together, I would be worried about subacute combined degeneration of the cord, secondary to nitrous oxide toxicity. It's a pathology that's becoming more and more prevalent, and one we need to always have in the back of our minds.
So we've gone through clinical presentation, we've gone through his examination. So what investigations do you want to do then? How are you going to manage this patient in the acute period?
Well, we're going to want to get a CBC looking for a macrocytic anemia, a renal function, liver function tests, electrolytes, and thyroid function as standard, with the HIV and syphilis if they're felt to be indicated. Given our main differential, we'll obviously want to order B12 and folate as well. What's interesting about nitrous oxide toxicity in this context is that it leads to a functional deficit in B12. So actually, in a lot of cases, the B12 may be normal. Given this, there's 2 tests you're going to want to order in addition to assess for that functional deficiency. Number 1 is MMA, or methylmalonic acid, and number 2 is homocysteine. But there's a crucial detail. They should be ordered before initiating treatment, as commencing B12 injections before ordering these tests may result in falsely reassuring results. Now, that said, it's important to strike a balance. B12 and folic acid should be started on the day of presentation to avoid disease progression, and the patient should be counselled on ceasing nitrous oxide consumption.
Fair enough. Okay, that's impressive. So in a patient with nitrous oxide use, we should think about neurological symptoms, and then we need to do 3 specific tests. So 1, we need to check a B12 and a folate level, even though they may be normal. Number 2, we need to do a methylmalonic acid. And number 3, a homocysteine level. And then we need to start B12 replacement and folic acid afterwards as soon as possible, while emphasizing the importance of nitrous oxide cessation. So I guess the question that comes to my mind is, do we need to refer this patient for admission, or is it possible to discharge him home? I know that in some cases it's usually possible to manage this in the community, but the 2 most important things in facilitating this is taking a good social history, which you have, and giving patient education about the administration of B12. The results of those investigations we've sent can take a number of days to be reported depending on your facility. But if the patient is reliable, their symptoms are mild, and we can organise a neurology or other appropriate follow-up within about 1 to 2 weeks, I feel we might be able to send this guy home to finally get some sleep.
Yeah, absolutely. I think that would be reasonable. He seemed pretty bashful when I was speaking to him, and he's had a few scares with friends of his with similar symptoms. He's happy to take the injections and to come back to his appointment. A semi-urgent MRI is the next thing in the list, though. If possible, this should be done within a few days of their presentation, or even while in the department. But if they'll be returning to the clinic and are reliable, an outpatient one's reasonable. Follow-up's also important because we need to ensure this guy doesn't go back on nitrous oxide. The risk of long-term, irreversible neurological impairment in the absence of cessation is a real one.
And I guess organising that follow-up can be difficult if there's no actual formal pathway for these patients. But it's absolutely something that does optimise these patients' outcomes. And so, Liam, you've deemed this patient is suitable for same-day discharge. He has his B12 and folic acid prescription. And although the evidence is a bit scant, you discuss at length with your neurology colleagues and decide to give him 1 milligram B12 injections daily, along with 5 milligram folic acid oral replacement daily for a week. and then he'll be followed up in the clinic, and they'll probably be transferring him to weekly supplementation depending on his symptoms. You counselled him extensively on nitrous oxide cessation, and off they go. A job well done, Liam. What would you say your top 3 take-home points are from this case?
Yeah, it's tricky to only choose 3. I guess number 1 for me would be just having nitrous oxide in your differential. Whether it's that there's a history of vague but progressive neurological symptoms, or in a younger person with other recreational drug use, or even if the history and exam point to the diagnosis in the absence of disclosed nitrous oxide use. Sometimes patients don't want to disclose their use, or sometimes they don't even consider it a drug, as you can buy it online legally for cooking purposes. Number 2, I'd say, is ordering that MMA level and homocysteine on the day of presentation. And finally, I think ensuring prompt follow-up, as you said, Leah, is key to optimal outcomes.
That's great, Liam. I think we might have been able to nip this one in the bud. And the only other thing I'd add is the same with all of these weird and wonderful presentations. Keep your differential broad. STIs, for example, are quite a common presentation with this, things like syphilis. If you're not 100% sure of this diagnosis, you probably need to be admitting this patient for further workup, or at least getting them even closer follow-up. So that's super, Liam. Let's leave it there for today.
Beautifully summarized. Thank you so much, Dr. Flanagan and Dr. Loughrey. Now, when you have a bleeding patient and they're hypotensive and you're waiting for that first bag of red cells to transfuse, you know not to give massive boluses of crystalloid, but the question sometimes comes up, is there a role for vasopressors in the bleeding patient? Here's our go-to EM trauma expert, Dr. Andrew Petrosoniak, on vasopressors in the bleeding trauma patient.
Let's start off with a case that hopefully helps frame a somewhat controversial topic, the role of vasopressors in trauma. It's a 45-year-old male who rolled over on an ATV and is brought into your ED. EMS tells you that he has injuries to his head, chest, and abdomen. His vitals are as follows: heart rate of 130, BP 75 on 40, resp rate of 35, O2 sat of 90% on non-rebreather. His temp and glucose are normal. His GCS is 11. The EFAST exam reveals a left pneumo and a positive FAST. His pelvis is stable. He's wearing a helmet and there's no focal neurodeficits, but you do still suspect a minor head injury. His cap refill and perfusion does appear to be pale and a bit delayed. Appropriately, you call for MHP. In the interim, you and your team wonder whether he should receive pressors given his hypotension and circulatory compromise. I think this is a great question, and one that definitely comes up quite frequently when managing sick trauma patients. When I first started as a trauma physician managing these patients, I'm fairly certain I kicked people out of the trauma bay for even uttering the words pressors, phenylephrine, or even Levophed. I was a staunch advocate that there is never a role for pressors in hemorrhaging trauma patients, and only a few exceptions, such as those with neurogenic shock. But if the patient is bleeding, forget about it. Now, I'll say that I have slightly, not much, but slightly softened my stance here. So let's discuss this a little bit more. To clarify, I think it's worth outlining where the long-held belief that pressors have no role in the management of bleeding trauma patients comes from. The two main priorities in modern management of bleeding trauma patients is 1, establishing hemostasis, and 2, restoring adequate blood volume for organ perfusion. Note, it's really not about replenishing the patient's perceived phenylephrine insufficiency. Nor does it really help to administer agents that vasoconstrict when there's not adequate blood volume to perfuse the vital organs. It's also worth noting that restoring perfusion before hemostasis can often be counterproductive, in that patients may actually bleed more as we increase the pressure and flow. So definitely any enthusiasm for vasopressors in trauma should be tempered as we better appreciate the pathophysiology that occurs in hemorrhage. With that being said, it is known that vasoplegia does occur in hemorrhaging trauma patients, and so there might be a theoretical upside to pressors as a means to reduce blood loss, help with hemodynamic instability, and ultimately buy some time to get to the OR or wherever you're going to go to achieve hemostasis. But every biologically active agent has a downside, and pressors are no different, including arrhythmias, potentiating blood loss with higher pressures, and increased cardiac workload. The evidence for or against pressors in trauma patients is scant at best, Most are cohort studies where patients who got pressors did worse. But it's hard to know what to make of that, since likely those are also the patients who were the sickest and the clinical teams were trying anything to maintain a blood pressure. One of, maybe if not the only RCT that I'm aware of, was a small study called the AVERT trial published in JAMA in 2018 that looked at low-dose vasopressin in bleeding patients. They did find a significant decrease in the need for blood products, though it's not surprising, since if vasopressin increased the BP, clinicians probably held off on further blood products. Importantly, while not the primary outcome, there were no differences in the patient-centered ones, like ICU length of stay or mortality. Though, there weren't more complications in the vasopressor group either. Interestingly, the European guidelines on hemorrhagic shock state, and I quote, "In the presence of life-threatening hypotension, we recommend administration of vasopressors in addition to fluids to maintain target arterial pressure." End quote. Notably, this is a strong recommendation, but a very low-quality evidence. And I think if you read into this a little bit more, this is really in the context of, quote, life-threatening hypotension. And in my mind, that's got to be pressures in the 40s, 50s, 60s. So to summarize, there's really insufficient evidence to guide the use of vasopressors in early trauma resuscitation. There's definitely not any substantial evidence that suggests it's helpful, and maybe there's a signal towards harm. Though, if there's one thing I've learned in medicine, it's whenever I've made absolute statements like never or always, I usually end up being wrong. So, do I think there's a role for vasopressors in trauma? Probably yes, but it's minimal, and it's almost never the first thing that should be prioritized. Here's a few questions and answers that will help outline how I see pressors in trauma. Number one, is the patient's cause of shock due to hemorrhage? If yes, then my priorities are hemostasis, i.e. getting them to the OR, and restoring blood volume, i.e. activating the MHP. But sometimes that's not enough. Now, I'm not talking about the patient that has a systolic blood pressure of 90, but one that is 60/40 and is about to arrest. In that case, I'll start a norepi infusion, but only really after I've activated MHP, or while that's happening. Remember, if the nurse is mixing a norepi infusion, they can't give blood. And priorities are so key. In addition, I'd probably supplement with some push-dose pressors to avoid cardiac arrest for a few minutes. How often do I give pressors? Well, probably less than 5% of the hypotensive trauma patients I see. I can't emphasize enough. Blood first, and only once that's running might I consider a pressor to optimize perfusion. Intuitively, a background infusion of norepi does seem like not a bad idea sometimes, especially for patients that are undergoing transport to another institution. But again, this should happen in conjunction with a well-functioning MHP. What about phenylephrine just before intubation? I really don't like this approach since it's not fixing anything other than a number, and I'm not likely improving perfusion. It's pretty rare that you have to proceed with intubation immediately and can't wait to resuscitate first. If you want to give it, I guess it's fine, since I don't have evidence one way or another. But I make sure that it's really only after the patient has had a few units of blood products, or in the patient that's peri-arrest and I'm just trying to maintain any semblance of cardiac output and blood pressure. Do I ever use vasopressin, like in the study that was outlined in 2018? Virtually never in trauma. I think that's a system-level decision and maybe is the way of the future, but I don't plan on trying it ad hoc without a well-defined institutional protocol. What about if I suspect there's neurogenic shock? First, there needs to be actual clinical suspicion for this. And what does that mean? Well, quite simply, the patient's legs have never been observed to move, something to that effect. So if that's the case, especially if the patient's awake and you've tried to evaluate them and they clearly have no motor function below the level of the injury, then I'm often going to start a norepi drip. Weirdly enough, I haven't observed these patients to usually bottom out their pressure, though I guess it's possible, but it usually just sits around 80/40 with a heart rate of 80, what's sometimes called the 80-80 rule. Maybe along with neurodeficits, your clue that there's neurogenic shock. If I also suspect massive hemorrhage, then I'm probably going to focus again on blood volume restoration first and only after a few units, then add on norepi. So in summary, is there a role for vasopressors in trauma? Maybe, but only in a minority of cases and rarely is it your first option. The vast majority of trauma patients require blood volume restoration, and all efforts should be directed towards that. In the future, we might better learn there's a supplemental role for pressors, and there still probably is some role in the peri-arrest or persistently hypotensive patient despite MHP, but that's probably it. So back to our case, as a reminder, there's a patient involved in an ATV rollover with a positive FAST and a left pneumothorax and a BP is 75/30. My three main priorities would be to decompress the left chest, activate MHP, and then work on arranging transfer to the OR, either on site if it's our trauma center or to another institution if I'm in a community center. I'd hold off intubation until they had at least a few units of blood products and the MHP was rolling. I'm not really entertaining pressors here unless the patient keeps dropping their pressure despite large volumes of blood products. Maybe after 3-4 units and the pressure is still less than 60 or 70, then I'd start the norepi. Because I know there's an opportunity cost by diverting my team away from what this patient really needs, which is blood and hemostasis.
All right, that about wraps it up for this month's EM Quick Hits. Hope you learned a little something about HIV PEP and PrEP with Megan Landis, about pre-oxygenation before intubation with Justin Morgenstern and George Kovacs, about blast crisis with Brit Long, about nitrous oxide toxicity with Leah and Liam, and about vasopressors and trauma with Petro. Now, Dr. Petrosoniak will not only be speaking at the EM Cases Summit, but if you sign up for the simulations in Sarah Fui's virtual resus room, you might just be lucky enough to have Dr. Petrosoniak running the sim and doing the debriefing with you. Space is limited for the sims and for the symposiums, so please do head to emcasessummit.com soon to register before it sells out. Until next time, take it easy.